Hi, I'm Dr. Ambre Lucidi. It's my pleasure to welcome Professor Sébastien Lustig today at PCO. So you're a leading orthopedic surgeon working at La Croix Hospital in Lyon, France. You specialize in hip and knee surgery. You're the current president of the French Hip and Knee Society, and you're very involved in research and education worldwide. So welcome to PCO, and thank you for giving this interview. So we'll focus a little bit on patellofemoral joint replacement. You will be talking about the technique. So could you tell us a little bit about the number you have in your practice or in your department per year of PFGR?
Yeah, we do roughly 25 to 30 isolated PFGR per year. And you have to add another 15, by comp, which is medial uni plus PFG. So in total, it's around 40 to 50 a year, which is pretty big numbers related to very specific indication.
All right. Could you tell us a little bit about the current indication when a patient comes in your department? What do you target?
So usually you have two specific indications. You have the young and active, 40, 45, who had the long history of patellofemoral instability. These ones want to go back to sports, go back to their leisure activity, and they have isolated patellofemoral arthritis. So for these ones, these patients, usually female patients, active, we do a monocomp, which is like a PFG isolated, and usually this is a very good indication. They want to go back skiing, hiking, so this works well. The other indication is more on the elderly side, so 80, 85 years old, medical comorbidities, isolated PFG, sometimes some minor arthritis of the femorotibial joint. You want to do a light surgery, and then you can do also, a PFGR isolated, like a unicomp, medial uni. Sometimes we do it for elderly patients, so it's the same.
And how would you optimize these two types of patients?
So so they're two different. The elderly ones, you try to make sure, we optimize them on a medical standpoint. The young and active, we try to more work with the physio to make sure, on a muscular standpoint, they're ready for the surgery, which is not so easy because usually these patients, they have a long history of patella pain, patella instability, so their quad muscle is quite weak. So these are two different situations.
So looking more about the technique, could you tell us a little bit about robotics and pin placement for such
No, it's a good point. So first, robotic surgery has really changed my practice for PFGR. I think this is the best indication for robotic because this surgery, because we don't do so many, needs some fine tuning and it's not easy to do with standard technique. With PFGR, with robotic, you have a pre-op CT, so you can fine-tune how you're going to position your implant. And talking about the pins, you only have pins on the femur, and you can put them intransgional. So usually we do either a small mid-vastus or a sub-vastus approach, and then you can put the pins intransgional. So it's really not an issue, different from the other indication where you might have to do extransgional. For PFGR, it's intransgional.
Would the pin placement differ if you would combine it to UK?
So that's a good question. If you combine it with UK, usually you do a pretty more extended approach, so it's even easier to get them intransgional, but you also have to do it on the tibia side. So yeah, the incision is slightly bigger.
Could you tell us a little bit about your preferred implant for PFGR at the moment?
Yeah, so that's a good question. You have two options. You have the inlay and onlay. When we do robotic, it's inlay, which means that you're going to resurface the trochlear. The problem is if you have a severe dysplasia, you need to be a little bit more inventive because you're going to have to recreate the anatomy, and that's where the pre-op CT is useful for this particular implant.
Okay, could you tell us a little bit about patella tracking and robotics?
Yeah.
How does it help?
So that's the main advantage because you can measure the anterior offset, not only the tracking, but how you restore the anterior offset. And one of the things we learned from robotic is usually when you do PFGR, you increase the anterior offset, which might be the reason why some of the previous design have failed, because too much pressure on the patella. With this technique, you can really make sure you're restoring the tracking, but also the offset, so you don't overload the patella. And again, this is something I'm going to show in my video later on today, and I think this is a very good point with robotic.
Okay, and what do you tell your patients when you're looking at outcomes?
So the first thing is these patella patients are not easy. So you need to tell them before that the rehab might be a little bit longer than what they expect. It's going to be some time to recover the quad muscle. I was talking about the extensor mechanism. You're going to put the patella back on track, so they will need some work. So I tell them surgery is 50% but the rehab will be 50% and might take a little bit more time than what they were expecting. It's very important to inform them before the surgery.
All right, so what about hospital stay and rehabilitation? Could you?
So hospital stay for PFGR usually is ambulatory. So we keep them in hospital just for the day, sometimes one extra night if they are, isolated socially. But then the rehab, usually they don't go in rehab center, they need to have a good physio, but because we ask them to work with their physio before the surgery, the program is, as you mentioned, optimization, and there's post-op rehab protocol, usually 2 to 3 months.
Okay, so when do you see them back in clinics?
So we see them back usually between 6 to 8 weeks post-op to make sure, they go in the right direction. But it's not unusual to get a phone call from the physio after the first 3 or 4 weeks, and we see them earlier to give them some direction, to emphasize about range of motion or, muscular work, depending on the situation. So this needs a little bit more follow-up than the usual knee arthroplasty that we're doing regularly.
All right. So for a surgeon who is more used to instrumental technique,
Yep.
going into robotics, what piece of advice would you give them for their first one to be successful for PFGR?
So I think, stick to the classic indication. Don't push the limit. Indication is the key. And then regarding, the procedure, I would say this is actually much easier than the conventional. So the learning curve is quite simple. As long as you understand, the pre-planning, you take your time, and during surgery, you follow the steps. So this is something we're seeing some videos before is quite useful, or coming to PCO to learn the technique makes sense.
What are the 3 complications you would encounter and how to avoid them with robotics?
Yeah, so 3 complications. I don't think it's specific to robotic. I think the first one is if you overload the anterior compartment, would be some, little stiffness, so the rehab process might be a little bit longer. The second one, I would say, is infection, which is not usual, but it's something we need to tell the patient. And then the third one, I would say, if you don't restore the tracking properly, is clicking or notching or a little bit of not instability, but patella maltracking, and that's where you might have to add an MPFL reconstruction. So you combine soft tissue with PFG. I never do it in one stage, but I have 2 cases where I had to do the MPFL later on because it's really hard to anticipate that during surgery because it's passive, and actively it might be some difference. But so just tell your patient you're going to restore the anatomy, and if the extensor mechanism is not strong enough, you might have to add some soft tissue procedure later on, but it's unusual.
Okay, so regarding infection, what protocol for antibiotics prophylaxis do you use?
That's a good question. So no, we don't use the 1 week antibiotic protocol from Dr. Meneghini, which is quite popular, in North America. We stick to this recommendation. So we do 1 day, 3 injections, 1 hour before surgery, and the 2, during the day after surgery. So classic cefazolin, and if they're allergic, we go vancomycin. There's nothing specific, and again, the risk is pretty low.
All right. So you have built a successful career with a busy clinical practice and also an involvement worldwide in education, in research. What piece of advice would you give when you reflect on everything to surgeons who would like to have a busy clinical practice and be involved worldwide, internationally with the orthopedic community?
Yeah, so the first, the secret recipe, I don't think there is one, but it's working hard. There's no way you can escape that. Work in a very good environment, having a good team, working with good people. I'm talking about nurse staff, I'm talking about, your partner. If you're on your own, it's really hard because you need to have people to back you up when you're traveling, your rights. And also working as a team is always, better on the long terms. So I think, choosing your partner and choosing your team is probably the key for success.
Well, thank you very much for your time. It was a pleasure.
Pleasure.